Hi, and welcome back to Mizan Coaching. My name is Dr. Mizan, MD, and oh, the camera is a little wonky. There you go, much better. And yeah, so thank you for joining my. I'm just gonna hold this. So thank you for joining my live. And for those who don't know me, if you're just joining in, I am Dr. Mizan. I am a licensed family medicine physician, and I run Mizan Coaching LLC. If you want to work with us, our email is mizancoaching@gmail.com. But basically, I provide medical legal expertise for everyone, really patients, hospitals, clinics, independent parties. If you need a licensed physician to help you with your medical malpractice, personal injury cases, or allegations, or if you just need an actual physician to help your hospital or clinic not get sued, I'm your guy. And I have clients all over the U.S. and I'm doing this for patient advocacy. So again, I always give that introduction. I feel like now thankfully we reached over 500 subscribers. We've garnered over 50,000 views on our channel, so really grateful for everyone for that. And today we have a very interesting and really this is one of the most frequently asked questions that our business gets. It's what are the most common medical legal cases? So basically, I title this Doctors Behaving Badly, the Wildest Medical Legal Cases, and How to Avoid Them. And again, this is extremely important, right? Because as physicians, if you watch my previous videos, you'll know that 100% of physicians will get sued. And this doesn't mean that you yourself, if you're a practicing physician, it doesn't mean that necessarily you will be the target defendant, or rather the primary defendant, but it might be your group or your clinic or your hospital or your department might be implicated in a lawsuit. And so basically, you will be one of the defendants, and we call this a shotgun method. So this is something that a lot of medical malpractice attorneys use. Like, they don't know who messed up or who dropped the ball, and so they basically name like a dozen different, like a dozen different defendants. And so what happens? Oh, hi, thanks for joining. So basically, what ends up happening is that, like, many physicians and nurses get implicated in these cases. Um, and so, like, then the actual work can begin. So usually depositions begin. A deposition is basically when, like, doctors and nurses are asked, like, hey, like, how do you treat pneumonia? Thanks for joining, everyone. So it's a deposition is basically when, like, many people, like doctors and nurses, are asked, like, okay, like, this happened to Mr. Rodriguez or Mr. Camille or whatever, and do you know how to treat pneumonia? If you know how to treat pneumonia, then why did he end up in septic shock, right? So these are the things that medical malpractice attorneys ask, and this is what they look for. So again, if you are a practicing physician, meaning a doctor, an MD, a DO, if you're an NP, a PA, if you're a registered nurse, someone interested in joining the healthcare world, please free to contact us at mizancoaching@gmail.com, and we're happy to work with you directly. Anyway, so let's go through the let's go through this list because this is really it's very fascinating. So the number one reason why medical malpractice exists, even, Laura, good to see you. How are you doing? It's been a while. So the number one reason why hospitals, clinics get sued is really because of misdiagnosis or delayed diagnosis. Um, and again, these are very different things, right? So misdiagnosis basically means that the wrong diagnosis. I'm good. I'm good. Yeah, my wife and I just came back from a 1 week vacation, so we really needed it. We're both extremely tired doctors, so it's like a vacation is very rare. So it's very nice. Hope you're doing well. Yeah, so misdiagnosis basically means, like, for example, like a patient with chest pain was sent home with acid reflux, but later had a fatal heart attack, like a myocardial infarction. And maybe the EKG was misread, right? So, so this would be called a misdiagnosis. So a misdiagnosis means that the actual diagnosis was not, implicated, and the doctor or the nurse or whatever thought that it was something else. A delayed diagnosis is very different. So a delayed diagnosis means eventually they found that, oh, like, this person had art, coronary artery disease, but it was done way too late, right? And again, drop in the comments if you guys relate to any of these, like if you've ever experienced something like this. And again, like if you do have any questions, like again, this is an ask me anything, so think of it as your own private doctor, right? So any questions you guys have, like feel free, and hopefully I can answer them. All right, so that's what a misdiagnosis is. So again, a misdiagnosis is when let's say you go into the hospital, you go into the ER, and you're saying, "Oh, I have this like really bad cough," and the ER doctor or nurse is like, "Oh, it's just a cough, just go home." That and they just say it's just in the diagnosis and the assessment and plan, they just say, "Oh, it's just a cough," right? But they fail to do a chest X-ray. They fail to do a CBC or a complete blood count to see leukocytosis. Um, and let's say, like, what if you had pneumonia, right? So like if they did those appropriate tests, they would have diagnosed you with, let's say, bacterial or viral pneumonia. And if they did those tests, they would also find that you are now septic, right? And so because of that, you would have to be admitted to the hospital, you know? So because those things were not done, the patient was sent home, and let's say that, God forbid the patient experiences septic shock at home, and then comes back to the hospital, it's diagnosed, but now, they need to get some sort of invasive procedure or some, some very high strength antibiotics, and they need to be in the hospital for over a month. They go to the ICU, they go into shock, they need vasopressors, etc. So unfortunately, this happens a lot. So please watch my video on how to advocate for yourself, because no one will advocate for you. Okay. And again, this is coming from a medical doctor. Like I've seen hundreds of patients in my career, and the unfortunate reality is that we're just humans, right? Like we don't know everything. Like we only know what you tell us. So this is something that I tell my family as well. It's like always, always, like just talk tell your physician and your nurse everything that they need to know, because they're not going to magically know what you have, right? And many of the reasons why people get discharged from the emergency room is simply because they don't tell the doctor what actually happened. Like if they took drugs, if they, were out partying all night, whatever, like if there was something embarrassing, they usually don't tell the ER doctor, and then they're like, "Oh, it's nothing crazy. You can just do this outpatient or at home." So that's the number one reason. That's the number one category of cases we get. Like it's either misdiagnosis or delayed diagnosis. And the causative element here is that obviously if it's misdiagnosed, you're not going to get the correct treatment. And if there's a delayed diagnosis, then the treatment or the prognosis might be very poor. Because if you catch something too late, hey, thanks for joining. If you catch something too late, many times your body is already in a fight or flight response. So it's always prudent that physicians do a full workup on patients. So how do you avoid this? So this is basically the $1 million question, right? This is why people hire me to work with them. So how do you avoid this case allegation? So misdiagnosis or delayed diagnosis. Number one, use diagnostic checklists. So use for example, the Ottawa ankle rules, the heart score, and these will basically give you objective measurements for different diagnoses. Another thing you can do is document a full and thorough differential diagnosis and why you ruled out certain emergencies. And this is something that you really learn in medical school. But one thing that I've noticed, now it's 2025, I've been a full-time medical legal consulting doctor for almost 5 years now. One thing that I have truly noticed is that people are not doing full thorough differential diagnoses anymore. So when I was in training, and this wasn't that long ago, I'm not that old. I'm in my early 30s. When we would create a full differential diagnosis, it was thorough. Like we would create a very thorough differential as to what a disease could be, and we would rule out diseases. And so what we're seeing now is that people are either not creating a full differential diagnosis, or they're creating some crazy monster differential with like 20 different diseases, and it's unrealistic to rule out all those diseases, right? Okay. And some red flags: always consider the worst first. For example, a pulmonary embolism, uh, when a DVT-PE, when someone comes in with leg pain, cauda equina syndrome if someone comes in with back pain. And again, you're going to learn all this with clinical experience. So don't worry. If you're just getting into medicine, or if even if you just began your own practice, or if you're an attending, you will learn the warning signs and the red flags. So take your time, but also the point of me giving this information out into the world is so that you don't get into trouble, in the beginning stages of your career before the wisdom develops, right? Okay. Number 2. So the number 2 most common reasons why doctors get sued, and basically medical malpractice case, is medication errors. So a case example is a patient with renal failure was prescribed a full dose NSAID, or non-steroid anti-inflammatory drug, leading to GI bleeding. So I get so many of these cases. So someone with some sort of renal disease like CKD3, CKD4, a doctor or an NP or whatever, a PA, does not renally dose the drug, and then the patient has a like a cornucopia of problems, GI issues. You could have, salivation issues, you could have vision loss, you could have heart issues, you could have increased tachycardia, in low blood pressure. And so the best thing to do here is, if you are don't be overconfident in anything. And, double check renal and hepatic. Renal means kidney, hepatic means liver. So double check your renal and hepatic dosing. Use Hippocrates or up to date. Reconcile medications at every single visit. So what this means is, at every single visit, ask the patient, "Oh, Mr. Smith, are you still taking aspirin? Are you still taking atorvastatin, etc." So we call this medication reconciliation. And it's extremely important. And many physicians, because we're so stressed for time, and we see 20 patients a day, we don't take the time to do this, because by the time you finish answering the patient's questions, and their chief concern, once you manage their chief concern, you don't really have that much time left, right? So, but again, I highly advise to do medication reconciliation at every single visit. Okay, not just the annuals, but every single visit. Even if you're not the PCP, it's very important that you do, because I have been involved. I have been in cases where, like an OB-GYN or an oncologist is asked in a deposition, like, why did you not ask the patient if he was still on his antihypertensive? And it's like, you're an oncologist. Like, why do you care? Like, that has nothing to do with cancer. But in the medical legal world, you're still the doctor. You're still providing care. So, and that's the difficult thing about this world. It's like, if a lawyer finds something, they're going to use it against you, right? So make sure to cross your T's, dot your I's. Okay. And another thing you can do as a prescriber is to avoid high risk prescriptions. For example, opioids and benzos at the same time, long-term PPIs like omeprazole without indication. And this is very important because, many of these drugs are just continually refilled. So let's say that, Mr. Smith is on omeprazole, right? Like every single day. And then he changes PCPs. That new PCP needs to do a full medication reconciliation. Usually this, I would say it's not most of the time, but many times physicians just refill the medications. They don't ask. They just refill, and the patients aren't aware, right? The patients, thanks for joining. The patients are not aware that they should not be on, omeprazole for greater than 1 week. Because if a doctor refills a medication, what it's telling the patient is that, oh, I should be taking this medication, right? So again, if you are a prescriber, a doctor, an NP, a PA, always ask the patient, like, why are you taking this med? Are you still taking it? Um, have you had any issues with it? Okay. The third most likely cause of medical malpractice is a failure to obtain informed consent. So, an example, a patient sues their doctor after a steroid injection caused a retinal tear. Consent form only listed blindness as a risk. So, this is sort of a gray area. And I'm being very honest here because I've been involved in many, many, many cases where the informed consent form or this discussion is usually defense friendly, meaning that even if a physician explains every single thing under the sun that could happen to a patient, something can still go wrong, you know? So I understand that this is a common allegation, but it's not a very strong one. And the reason why is because medicine is not black and white. Just because you told a patient, "Oh, this could happen, that could happen," and you forgot to say, "Oh, this other thing could also happen," but it is quite rare. I've seen these cases go either way, either plaintiff friendly or defense friendly. But anyway, so the best way to avoid this issue is number one, use procedure specific consent forms. So, for example, use scribes or templated EHR forms. So, for example, don't just use a generic surgery informed consent, use it for that particular surgery. Like, for example, an exploratory laparotomy or an appendectomy informed consent form. Don't just use some generic form. Number two, document the conversation. This is very important. So, discussed risks, for example, discussed risks A, B, and C, including the serious but rare complications. This is important because then the patient can't accuse you of saying, "Oh, hey, but the doctor never told me that this weird, rare thing that I found on Google could happen to me. If I knew that, then I wouldn't have gotten the surgery." Number one, that's a very poor argument because if you're in the doctor's office and you need some surgery or some procedure, there's probably a good reason why you need that procedure, right? Otherwise, you'll just be living with pain or with some issue or some disease. The other way to avoid this is to avoid vague language. Instead of saying rare complications, say 1 in 1,000 risk of nerve damage. And again, this is really just nitpicky, but these cases do fall on our desk, so I thought it would be important to bring this up. Again, like failure to obtain proper informed consent. The best things to do is to explain everything to your patient. Use procedure specific consent forms and just document what you spoke with the patient. Okay, number four, the fourth most likely cause of medical malpractice cases. And again, these don't mean successful cases, right? Like these are just the top 10 that I found from my records where they just keep popping up. So number four is just poor documentation. So a case example is a doctor lost a lawsuit because the note said discussed risks, but did not specify which risks. And again, this does happen. Like I have had quite a few cases where I was very just like shaking my head at my colleagues because I was like, why did you not write down that you did these things? And again, please watch my video on how to document things because that will help you. That one video will probably help you from any lawsuits in the future. So how do you avoid this? So use a template, like for example, SOAP, so subjective objective assessment plan. So use SOAP notes. So include patient refusal or non-compliance. For example, patient declined colonoscopy despite discussion of colorectal carcinoma risk. So that's very important because if you document that, then if somebody does an audit or someone does some sort of record review, they're going to see that like, oh, okay, so this doctor actually did speak with my client, right? And then that lawyer is going to just throw away that case. That's usually what happens. Timestamp critical decisions. So, for example, called cardiology at 3:15 p.m. No callback yet. This is very important because many of my ER cases are just lack of documentation. Like the ER doctor did do all the appropriate things, like follow the standard of care. They just didn't document that they did. So if you don't document it, then no one else will. It's very rare that a nurse says, "Oh yeah, my doctor did this, and this at this time." So if a patient says, "Oh no, the doctor never did these things, but you actually did," you need to document it. Otherwise, they can use that argument against you. And the third thing, which unfortunately I see a lot, is never ever alter your medical record. So it's actually a felony in many states in the United States. So many people feel like, oh my gosh, I'm being sued. I should go back to my medical records and change something or add more information. Don't do this because when they do an audit, it's called an audit trail. They can actually we can Everyone can see actually, your hospital administration, the attorney who's seeking medical records, the patient can actually see that, oh, Dr. Rodriguez went into the EHR and changed the note from a year ago to now include more information. Everyone can see that in the audit trail. So don't do that. Just mea culpa, like say it's my mistake, I should have done this, and just get your punishment from your hospital. Better to do that than to lose your license and all that, which happens. Okay. Yeah. Again, the whole point of my channel is to tell all my physician colleagues that these things do happen, unfortunately. Okay. I need some water, so give me 1 second, guys. And yeah, go ahead and ask any questions if you have any. Okay. So number 5 is communication failure. So an example is a patient's abnormal pap smear results were never communicated, and the patient was later diagnosed with cervical cancer. We see a lot of this. So if you do a test, even if it's negative, just tell the patient. Or what I would do what I would do is, like, I would say, look, Mrs. Smith, if there is something positive or abnormal, I will call you tomorrow. So if you say that, thanks for joining, MS. So really good to see you. So if you order a test and it is abnormal or positive, then make sure that you tell the patient pretty much the next day. If it's a red flag finding, tell them immediately if you can. And so that just ensures closed loop communication, right? Because a patient might have access to their portal, they might not. So, for example, how do you avoid this closed loop communication? So, for example, I'll call you with results by Friday. If you don't hear from me, go ahead and call our clinic. Another way is to document follow-up attempts. For example, you can write, I left a voicemail on May 1st and a letter was sent on May 5. And you can also use patient portals for results and read receipts. So you can tell the patient, hey, you have a portal, go ahead and access it. That way you can see all your results. And if you do have any questions, feel free to email me or give our office a call. Okay, so the number 6 most common reason for medical malpractice cases is ignoring patient complaints. So, for example, a patient repeatedly complained of post-op fever or wound redness, later had necrotizing fasciitis. We see this quite uncommonly, but it is still there. So, how do you avoid this? Take all complaints seriously. Even quote annoying patients might sometimes be right. And this is why, as physicians, we need to stay as unbiased as possible. Remember, we're all humans, so it's difficult to stay unbiased, but try to take all of your patients' complaints seriously. Document exam findings. For example, there was no erythema or redness drainage today. However, advise the patient to return if the fever persists. So what this is doing is that it's protecting you from any future changes in the patient's condition. And when in doubt, refer the patient out. So, for example, send the patient immediately to the ER to rule out sepsis due to persistent tachycardia. And again, like it's just simply good to it's good habit to do this for patients. For example, like if you work in an outpatient clinic, you might not have the full resources or expediency in order to do a CBC the same day. And if a patient is tachycardic, has low BP, signs of a fever, they might be in septic. They might go into septic shock immediately. And there's not much you can do in your clinic. So it's really just best practice just to send them to the ER if they meet those ER admission criteria. Okay. The seventh most common cause of medical malpractice is surgical and procedural errors. I am not a surgeon, so I don't do any of these cases, and I don't really know much about surgical cases. However, a case example would be a wrong level spinal surgery leading to paralysis. And my colleagues who do work, my surgical colleagues that I do sometimes refer to, they do tell me that these things happen. Many times they're really just honest mistakes. And at that point, it really goes to a committee of, like-minded surgeons who have to explain to the jury if this was just an accident or if it was malicious, or and usually it's not malicious. Many of these cases get thrown out or settled by the hospital, but it is something to note. So best how to avoid these: so do timeouts prior to performing surgery, verify the site, the side meaning left or right, and the procedure with the entire team. Use a checklist such as a WHO surgical safety checklist, and you can also check for document anomalies. For example, unusual anatomy. So consult someone like a senior surgeon or a cardiologist. These are rare, but they do occur. All right, the eighth most common cause of medical malpractice is boundary violations. For example, a doctor was sued for texting a patient after hours, leading to a romantic relationship. And, we get so many of these questions when we're studying for our USMLE step exams. And yeah, boundaries matter. And in this world, boundaries matter tremendously because there is a power dynamic, and physicians have privileged confidential information that other people might not. Many times the doctor knows things about a patient that even their own spouse does not know. And so that's why the ACGME, the AAFP, the AMA, etc., the AAIM, they all have rules stating these very clear boundaries that we cannot accept gifts, we cannot engage romantically with our patients. No, unless they're not your patients anymore, you cannot do any of these things. And the reason why is simply because of that power dynamic. So, number one, to avoid these, no social media contact at all with your patients. 0%. Like, do not friend them, do not have anything to do with them. Only use secure EHR or EMR messaging. Number two, avoid dual relationships, for example, treating your own family or friends. And number three, document professional boundaries. For example, patient asked for personal advice. I redirected the patient to clinical care. And again, these things do happen, and we have all these medical dramas that talk about it, right? Like Grey's Anatomy and The Pit and all this. But in the real world, there's a lot of punishment for these types of boundary violations. Okay, so the ninth most common cause of medical malpractice cases is failure to refer or follow up. I've had so many of these cases. And again, I am a family medicine PCP, so I sort of knew my wheelhouse. Like I'm not going I'm not going to pretend to be a cardiologist or a gastroenterologist. I know what I'm good at. I know what I don't know. And well, usually I do. And again, like a good seasoned physician knows their limits. They're not going to like, for example, a cardiologist pretending to be a nephrologist or ordering nephro meds. That's you're going beyond your scope of practice. So a case example is let's say a family medicine PCP managed uncontrolled hypertension for many months without any referral to a cardiologist. The patient later had a stroke. So in this situation, if I were the PCP, and I've had many patients like this, I just send them to a cardiologist. Like, it makes my job easier, and the patient gets more focused care from someone who has a lot more experience dealing with recalcitrant or uncontrolled hypertension. That's not really something that a regular PCP is trained to handle at that point. Basic hypertension essential, it's totally fine. But once a patient is on 3 different medications and nothing is working, don't try to be a hero. Just, we have a whole system in place, so make sure you contact your colleagues who are more suitable for a more serious, or for a more serious situation, or a situation that requires a different perspective. Always document. So number 1, know your limits. So refer when standard treatments fail. For example, an A1C of greater than 9% on maximum metformin. Send them to and send them um, to endocrinology. Document referrals referred to neurology for headaches, pending insurance approval. So always document whenever you do a referral, and track those consults. So follow up with the patient if the patient has not been seen by the specialist in a month or two, whatever your clinic's usual standard turnaround time is. Okay, so the 10th reason, or the 10th most common reason why patients sue physicians or clinics or hospitals is EHR-related errors. So, for example, a doctor clicked normal on a templated exam, missed a skin melanoma because they didn't actually take a look. And we see this a lot. We see this more with like interns in residency who, they're so tired that they just like copy paste. They just use templates. They don't, they just say that they saw every single organ system during a physical exam. But if you didn't see it, you didn't do it, right? So it's actually better to customize your physical exams based on what you actually saw. The reason why is because later, if let's say a nurse is doing a skin integrity check and they're like, oh my gosh, like there is a stage 3 or 4 sacral decubitus ulcer, they're going to look at your note from the day before, and you wrote, Dr. Smith wrote, the skin is perfectly fine, healthy, there's no issues. And so then they're going to question you, even though you have nothing to do with the case. They might question you and say, hey, did you actually look at the skin? No. Then why did you write that? You're a doctor. You're supposed to write the honest truth. So, how to avoid this? Customize your templates to force critical thinking. So, for example, skin, are there any moles, any irregular borders? Avoid charting by exception unless you're absolutely certain. So, what this means is like, using a templated, physical exam ROS, or review of systems section, and then just changing it whenever something is different. So, avoid doing that. No, in the real world, people don't really do that. People just put in, let's say that I just do an HEENT exam and a foot exam. That's all you write in the physical exam. You don't have to say that you saw every single organ system. And finally, don't copy paste old notes without reviewing for accuracy. And again, we get so many of these cases simply because they just copy paste. And so then, the doctor who took care of the patient a week ago is now basically on the hook, because we need to now, or not we, but like the attorneys have to ask that doctor, did you actually check the patient? Why did you write this? And if you did, then you can help us figure out when this decubitus ulcer was developed. Okay. And just a bonus, the number one way to avoid lawsuits, and this is something that I wrote simply because it's absolutely true, is communication. So building a healthy, friendly rapport is the best thing to do with your patients. And the reason why is they trust you, right? So patients who like you are less likely to sue you, even if you make a mistake. Bedside manner matters. Okay. So just for any comments after this, just, my question for you guys is, which of these surprised you the most? And I want you to comment any near misses that you guys have experienced. So I hope this helped. Again, this was a live session, so for those of you watching in the future, I hope you enjoyed. I hope you learned something from this. And if you do have any other ideas for future live sessions, please leave a comment below. I'm Dr. Mizan, MD, and until next time, take care.